Retrofixated iris claw lens from goat's eyes to human eyes. A very warm welcome to one and all. Today, I, Dr. Abhijay Luthra, a DNB resident at Dr. Shroff's Charity Eye Hospital, will be talking about why all of us need to know how to implant an iris claw lens and how to go about training for that. So, posterior capsular rents happen to everyone, and it's not always possible to salvage the bag of sulcus to be able to implant a PCOL. The usual technique that was used in these cases was to implant an ACIOL, but those come with their own set of complications. A ACD of at least 2.8 mm is required, a sufficient white to white distance is required, endothelial cell loss is known to occur post-operatively, and pupillary block chances are relatively high. This is where the iris claw lens comes in. Its advantages are the reduced chances of a pupillary block, no endothelial compromise, can be implanted in shallow anterior chambers, and there is no chance of any angle trauma occurring. The problem? They are not regularly implanted due to hesitance emerging from inexperience. So how did iris claw lens come to be? They were invented by the Dutch ophthalmologist Professor Jan Wurst in 1972, and initially the anterior fixated iris claw lens was invented. It was later modified by Brass and Neuhen as a retrofixated iris claw lens. The usual indications are surgical aphakia with no zonular or capsular support, which can usually occur as a consequence of a cataract surgery complication, a lens dislocation, an IOL dislocation, or an IOL exchange procedure. What are the possible complications that can occur in untrained hands? Are iris tears, IOL drops, iridodialysis, and endothelial damage during implantation. Let us look at a couple of examples of how things can go wrong when trying to implant an iris claw lens without training. So in this case, it's a cataract surgery complication. There is no bag. The surgeon is trying to implant an iris claw lens. They go ahead with the iris claw holding forceps, try to enclave the first side. Just look how traumatic is it. There's already an iris tear and there's bleeding occurring from the iris into the anterior chamber. They go ahead and manage to implant the second side too, but there's again bleeding and both the sides have torn through the iris. Now they have managed to enclave the lens, but there are going to be high chances of post-operative inflammation in this case, and the iris anatomy has been hampered. Another example is showing how the lens was enclaved on one side, and after that the surgeon went ahead with enclavation on the other side, and they did manage to enclave it. That's what we think. We see a slight dimple which disappears as soon as they inject Visco. The lens starts to sink into the vitreous cavity. This is where wet lab training for the iris claw lens comes in. So wet lab training for the iris claw lens initially starts with, it goes on pretty similar to how we train for SICS and phaco in the wet lab. First of all, we want to create a rhexis, and we'll go ahead with a regular SICS technique of delivering the nucleus. Create a well-sized capsular rhexis, which is fairly easy in a goat's eye, very similar to a human's eye. Go ahead with the sclerocorneal tunnel creation. As you'll see, I am going ahead with a temporal approach because the pupillary diameter in the superior approach does not allow for a human-sized iris claw lens to be practiced in a goat's eye. So it's necessary to go ahead with a temporal approach. The tunnel has been created. Going to enter with the keratome, and the entry has been done. Going to hydroprolapse the nucleus into the anterior chamber and deliver it with viscoelastic. And now we can start with practicing our iris claw lens enclavation. So create a second side port. What's most important is that both the side ports have to be exactly diagonal to each other to be able to get an easy enclavation. They should have a small intracorneal length so that we have ease of access while implanting. Go ahead with practicing how to making a PI using a vitrector. Can be done either superiorly or from under the iris depending on what the surgeon's approach is. And we go in and put in the iris claw lens into the anterior chamber. It's not necessary to align it exactly at this point, as we can go ahead and do that with the dialer. That's much easier since our chamber has more chances of staying formed at that time. Inject some viscoelastic under the lens, and then we go in with the iris claw holding forceps and the enclaver. It's necessary that we hold the iris claw lens exactly in its center so that our enclavation site is in the correct place. Go in and enclave it from one side, reform the anterior chamber with viscoelastic, go in again, hold it in the center and enclave it from the other side. A slight tug ensures that the iris claw lens is well enclaved and it's not going to drop behind once we're out. So once again, viscoelastic is injected and it's checked that the lens is in place. This is our wet lab training. A slight tap will also ensure that it is in place. So this is where the retrofixated iris claw lens comes in. It's the saving grace. The background of the slide represents what every resident is thinking as soon as they have a posterior capsular rent in the operation theatre. Our biggest fear, aphakia, can be saved with the help of iris claw lens. So now this is a video of how a well-trained surgeon can easily use an iris claw lens to save the day. This is a case of a dislocated IOL. We don't know whether that's due to any post-operative trauma or whether the primary surgery was finished in this way itself. So going ahead, the surgeon makes a side port, dials out the lens into the anterior chamber, and following this, makes an entry into the anterior chamber, pulls out the lens very atraumatically, sutures up the main section before going ahead with a vitrectomy. It's very important to clear all the vitreous from the anterior chamber, as that can lead to traction on the IOL. A superior PI has been made. The iris claw lens is put into the AC, dialed into the place after that using a dialer. Going in, the lens is held exactly in the center with the iris claw holding forceps enclaved on one side. Chamber is formed again with viscoelastic, and going in again, the lens is enclaved on the other side. And the lens is well enclaved. We'll just be pushing it back into the posterior chamber using viscoelastic very atraumatically, and that's a very well done iris claw lens, which should probably give the patient a good vision for a lifetime. Important points to be kept in mind are that make the side ports with short intracorneal tunnels for ease of access, do a good anterior vitrectomy, side ports should be diagonally opposite to each other. The tip of the forceps should align with the notch and the haptics, and make a PI always to prevent pupillary block. The possible contraindications are recurrent iritis, severe iris atrophy or tissue loss, uncontrolled chronic glaucoma, or corneal dystrophy or degeneration, as the endothelium is already compromised. IOL power can be calculated usually through the SRKT formula, or the A constant value of whatever lens you are using has to be put in. For us, it's usually 117.2. This is a study showing the visual outcomes of the iris claw lens implantation in patients. The difference between the pre-op and post-op visual acuity is significant in all cases, and the difference in the IOP is not significant in any of the cases. Hence, we know that it does not lead to too much of an IOP increase. A good surgeon is one who has minimal complications, and an even better surgeon is one who manages his complications well. Thank you.